Hi everyone, welcome back to part 2 of the leukemia series. We've spoken in the first video about acute leukemias, so now let's move on to the chronic leukemias. First, we have chronic myeloid leukemia. This is leukemia where there is uncontrolled clonal proliferation of myeloid cells. Okay, so this condition accounts for 15% of all leukemias, and it is also classed as a myeloproliferative disorder. It occurs commonly in adulthood, between 40 and 60 years of age, and is rare in children. As this is a chronic illness, the symptoms are often chronic and insidious. Unfortunately, because of this, most of the symptoms are very generalised and might not be recognised at first. The patient may present with weight loss, tiredness, fevers and the sweats. In some cases, there may actually be features of gout, which is due to purine breakdown as there's a greater cell turnover. Bleeding may be present due to a dysfunction of the platelets, and abdominal discomfort due to splenomegaly. In fact, the symptoms are so unspecific that approximately 30% of all cases of CML are diagnosed by chance. The best way to spot this disease is like the others, where patients show signs of splenomegaly, hepatomegaly, anemia, and bruising. Let's talk through what might be found on investigation of these patients. Well, firstly, the white blood cell count will be significantly raised, including all of the cells of myeloid lineage. So that's neutrophils, monocytes, basophils, and eosinophils. Hemoglobin may be low, and urate may be raised, as we've spoken about the symptoms of gout. Often there is a raised vitamin B12 level, and the bone marrow is hypercellular. Something about the chronic leukemias which is important to mention is the timeline of the events. Usually, the median survival is actually 5 to 6 years, but it's composed of 3 phases. The first is chronic, which lasts months or years. At this stage, there are very few symptoms, if any. Next is the accelerated phase. Here, there are increasing symptoms, like splenomegaly and significantly obscured blood results. Lastly, at the most serious stage, the blast formation, with features of acute leukemia and potentially death. Treatment for chronic myeloid leukemia is actually very interesting. We've developed knowledge about the genotype of this disease, and this has allowed us to develop specifically targeted drugs. So one example of this is imatinib, a BCR-ABL tyrosine kinase inhibitor. You've also got second-generation drugs, so for instance dasatinib. These drugs have mild side effects, so nausea, cramps, edema, rash, headache, and arthralgia typically. In some cases, where there is lymphoblastic transformation, ALL treatment may actually be beneficial. Lastly, stem cell transplantation is available and offers the only cure. However, there is a significant mortality risk. For this reason, it's often only offered to the youngest patients where the risks are at the lowest. Finally, we are on to the last type of leukemia, chronic lymphocytic leukemia, where there is a progressive accumulation of a malignant clone of functionally incompetent B cells. CLL is actually the most common type of leukemia, accounting for more than 25% of all leukemias. Factors that may increase an individual's risk of this cancer are mutations, trisomy, and deletions. Often, CLL is actually asymptomatic and is only found when doing routine bloods. Otherwise, the patient may be anemic, prone to infections, or have weight loss, sweats, and anorexia if the case is severe. You may find signs of leukemia in certain patients, such as these enlarged, rubbery, non-tender nodes, as well as splenomegaly or hepatomegaly. Now on to some tests. You would see some significantly raised lymphocytes in these patients. Remember, CLL is of lymphoid lineage, so you wouldn't expect a rise in other myeloid cells. In some patients, you may see levels of hemolysis. Where leukemia is advanced, and there is again bone marrow infiltration, patients may have this typical triad of low hemoglobin, neutropenia, and thrombocytopenia. Always make sure to watch out for complications in your patients with CLL. As discussed, they may present with autoimmune hemolysis, but in some cases they are prone to infection due to this hypogammaglobulinemia, so there's low levels of this IgG, meaning the patients are particularly susceptible to viral infections such as herpes zoster, as well as bacterial infections. Again, as we've discussed, in the later stages, the patient may experience bone marrow failure. Treatment is generally only given where there are bad prognostic indicators, such as patients with 17p deletions, or it's given if they are symptomatic. There are many available chemotherapy treatments. One example of this is rituximab. Radiotherapy can be given, as this helps lymphadenopathy and splenomegaly. Stem cell transplantation may be appropriate in certain individuals. And of course, treat each case individually and cater to what the patient needs. They may require transfusions, or as we've mentioned, one of the complications of CLL is hypogammaglobulinemia, so immunoglobulin administration might actually be necessary to prevent these recurrent infections. I think disease progression in patients with CLL is particularly interesting because it follows the rule of thirds. 1/3 of patients will never progress, maybe even improve. 1/3 of patients progress slowly, and the final third progress actively. Death in these patients is often due to infection, or the cancer can actually transform into an aggressive lymphoma. Okay, so we finally discussed all the different types of leukemia. The last thing that I want to address is actually treating this acutely neutropenic patient. This is when the patient has a neutrophil count of less than 0.5 times 10 to the 9 per litre. First, make sure that everyone encountering the patient has a full barrier protection on. Put the patient in a side room if it's possible. Next, try to avoid intramuscular injections as it may pose a risk for an infected hematoma. Check sites where infection commonly occurs, such as the mouth, axillae, perineum and IVI site, and take swabs as well of these areas. Check blood counts and cultures. Do a chest x-ray if it's deemed necessary. Keep the patient clean. For instance, wash the perineum after defecating and keep the skin clean with chlorhexidine. Check the patient's vital signs every 4 hours. And lastly, have a high-calorie diet and avoid foods with a high risk of microbial contamination. Okay, that's a lot of information, so here are some of the points you might want to take away from both part 1 and part 2 of this leukemia talk. As we know, leukemia can be divided into acute and chronic, as well as myeloid and lymphoid. Both of the acute leukemias present the symptoms of infiltration and bone marrow failure. So we're thinking about organomegalies, anemia, infection, bleeding, and potentially CNS involvement. In some cases, bone marrow transplants may be possible, but you should always weigh up the mortality risk for your patient. Don't just think about chemotherapy on its own. There are many other supportive treatments that need to be given, like blood products, allopurinol, immunoglobulins. Think about what is important for your individual patient. Chronic myeloid leukemia has slow, insidious symptoms. You may miss these signs, but pay attention to any organomegaly, anemia, or bruising. Chronic lymphocytic anemia, however, is often symptomless. If the patient has any specific genetic mutations, they may still require treatment, but up to 1/3 of patients do not progress or even improve. Lastly, treat neutropenia vigilantly. Keep everything clean and be obsessive. And that's it. I hope you've all learned something, and thank you so much for watching.